welcome to episode 4 of Bullhorns and Sirens with me, Tommy. We've got Sam.
Hey guys.
And we've got James.
Hello, how are we doing?
Good. We're all good. Are you well?
Yeah, I'm good, man.
Good.
Yeah, good to be back recording.
Yes, it's mad, isn't it? So today we've got a big treat for you, actually. We've got a guest speaker in. He's kindly offered to give up his time for you and us. He currently works as a critical care paramedic. He was one of the first CCPs to qualify in his speciality for the service that he works for. He's been on several TV shows, believe it or not. That includes 24 Hours in A&E and Booze Britain. That's a story and a half. He's worked 3 years on HEMS, which is the Helicopter Emergency Medical Service, and overall everyone describes him as a really nice bloke. Everyone loves him, everyone respects him. Please welcome to the mic, it's Jon Sanders.
Oh, cheers guys, thanks for the intro.
Did you like that intro, John? Was that
yeah,
right?
that was awesome.
It wasn't too cringe.
God, that's taken up most of the podcast, that intro.
That's it. Oh, there we go. No, right, guys, thanks for joining us, and we'll catch you next time.
Yeah, that's it. Yeah. So, as you noticed, I introduced you as Jon Sanders, and there's a bit of a story behind Jon, isn't
Explain why we call you Jon.
So it was actually Jon. But yeah, I got better hearing aids, and now it only takes people 2 times to say my name before they get my attention. But yeah, so I got a bit of a hearing problem, mild to moderate hearing loss, and I wear hearing aids, and yeah, it's just been one of those sort of things that you kind of sort of manage and deal with and get through life with, you know. But as long as I make people aware of it, generally people sort of tailor their communication towards me, you know.
Yeah.
But yeah, it's not too much. It's not too bad. Yeah, Jon.
So people go Jon.
Yeah. Yeah.
Oh, that's awesome. Well, there you go, guys. So that's why everyone calls you Jon. So shall we introduce what we're going to be talking about today? So we're going to get Jon to introduce himself. He's going to talk about his journey to becoming a critical care paramedic, and then we're going to talk a little bit about the CCP's role. CCP is critical care paramedic for those who aren't sort of in there yet. So we're going to dive into the CCP's role in post-ROSC care, breaking bad news, resource management, and with crews as well. And we've had a few questions in from the listeners, so we're going to ask Jon some questions about that. They're quite interesting. So Jon, can you just tell us a quick your journey really about how you got there, what brought you into the ambulance service, and then how you ended up being a CCP?
Yeah, sure. So I joined the ambulance service quite late. I was 29, and it's 2000, July 2000, and the only way you could get, in my trust anyway, to get to paramedic back in the day was to join patient transport service. So I did PTS for the first 8 months of my career, which I particularly, you know, it was the only way you could get to the next kind of level, which was trainee technician. But actually, it really helped me with my communication in terms of dealing with people with chronic illnesses, chronic injuries, etc. Because before then I really hadn't had any experience with that sort of stuff at all. So 2001 I did my trainee technician in-house course, which was 8 weeks long, including emergency driving, which I really enjoyed. Had my head in loads of books, you know. I bought Emergency Care in the Streets, Nancy Caroline, you know. I'd come home from my PTS shift and read about like different conditions and stuff, and just found it fascinating, you know, and I still do. And then I kind of thought I'll be happy once I qualified as a technician, you know. I didn't put myself in a box of sort of thinking I need to get to this kind of level and then I'll be happy. And I got to technician, I qualified, and realised that I wanted to know more. And I kind of really looked up to the paramedics that I worked with, mentors, you know, crewmates that I really leaned on and really sort of respected. And then the opportunity came again to do the paramedic course again in-house. So that was 3 months, including hospital placements. and again, just the more I learnt, the more I wanted to learn more. I always feel like I'm a student of the profession,
Yeah.
And I qualified as a paramedic, and I remember thinking, like, when am I going to get this epiphany of knowledge and sort of feel like I know everything and feel super confident going into any situation? And I remember like working with other paramedics and them being like really confident, and I go like, where'd you get your confidence from? Because I'm absolutely bricking it, going into some of these situations. And then like over time, one thing led to another, and you kind of go through different jobs and stuff, and they all help shape your practice and your sort of level of confidence, I guess. And then in 2007, kind of the world changed for my service. We merged with other services, and then suddenly there was an opportunity to go into different roles, and pretty much at the same time, like 3 or 4 roles came up that all sparked my interest. You had OTL, you had CCP, you had heart, and then you had in my trust like an urgent care specialist paramedic.
Yeah, and OTL is like an operational manager.
Yeah, it's kind of like first line manager, and before then that position didn't exist for my trust,
Oh, okay.
So yeah.
Who was your manager then?
So it was kind of like the equivalent of my middle line manager now would be my first line manager. So kind of
another step onto that chain of hierarchy, I guess.
Yeah. It's kind of like instead of going to the sergeant, you go to the corporal, if I could put it in that sort of, do you know what I mean? Like, yeah. So it was kind of like all these roles came out, and I was excited. Like I wanted to learn more, and I wanted to better myself. And I looked at heart, and that really excited me. I was like, wow, what is this new thing?
Yes, representing heart there. I'm loving that.
Of course he pipes up. But remember, he didn't choose heart, so it wasn't exciting enough.
No, clearly not.
There's a funny story to that. So primary care, I was like, yeah, that's because that was what I was going to most of the time. And
did it speak to you when you were looking at the pathways? Did you look at the primary care one and go, maybe, or did that just you wrote that off immediately?
No, I did think long and hard about it, because I still found it fascinating. I remember one of my mentors, one of my sort of senior paramedic crewmates, gave me a really solid piece of advice when I first joined the service, and he said, don't get bogged down with the politics, and don't get bogged down with the management and with the stuff that you can't control. When you're called to someone, whatever that problem is, it's in their eyes, their emergency. And if you look hard enough, you'll find something interesting that you can draw out of them and you can learn from. Yeah. And I kind of never really forgotten that.
So I like that. That's a really sort of like, if you do ever lose focus or anything, that's a really sort of good thing to remember, is that it is that person's emergency. Although it's not in our eyes, that's not an emergency, but actually to them, that's the worst moment of their life.
Yeah, that's it. Yeah, that's so true. And that can, because we just rock up at all these jobs and go job, and we don't actually realise that for those individuals, that's a crisis, right? So
it's true, yeah. Because we see it day in, day out, and to us, it just sort of becomes numb to us, and we're like, oh, okay, like we now have to deal with the situation. We'll give our best care and empathy to it, but at the same time, I guess you lose sight of in that moment. Yeah, that's their crisis.
So then, what made you choose critical care?
Yeah, so I was like, when I saw critical care, my heart was, and my soul and every cell in my body tingled, because I wanted that really badly, but I kind of also realised that I thought everyone's going to go for that.
Yeah.
Everyone's going to go for that. And what was interesting at the time was the year before those jobs came out, we had a new air ambulance in our area that had just started. Its sister ambulance had been established in another county, and kind of like we had this new air ambulance, and there was 5 paramedics from my area that kind of got selected for the air ambulance, and they were like legends to me. They
elite paramedics.
Yeah, like everyone knew who they were. Everyone had massive respect for them. and they were going to be part of the first cohort of CCPs as well.
Oh, okay.
And I remember looking at the advert and sort of thinking about those guys and thinking, I feel like quite arrogant, like going for this job. You know, I felt like I was a good paramedic, but I didn't feel like I was one of them.
Like good, almost good enough.
Yeah.
Okay.
But the other sort of part of me as well was like, I'm quite competitive, and I thought, if I'm gonna do this, then I need to put my heart and soul into it.
Yeah.
And so I didn't kind of allow that to stop me. So I went for it and got shortlisted, but I'd already started preparing, and I think that was the key. And then I got through the interview, through the assessments and everything else, and I actually failed the ALS, believe it or not. I failed the ALS on the post-ROSC patient. So I got, it was a VF for rest.
Let's take post-ROSC care off the agenda for today.
It's kind of like, what's this rhythm on the screen? And it was like this really, part of the assessment was this really poor sort of AED kind of, and I didn't diagnose it as sinus tachycardia. I just said tachycardia, and he failed me on it. It was really really harsh, yeah. And I got this letter, and like a week later, sort of thing, and I read it, and it said, "Unfortunately, you've been unsuccessful in this CCP, assessment." And I was like, I put it down. I was like, do you know what? I'm going to go for heart. I was going to go for heart, and that was it. I didn't.
Yes.
I didn't kind of like read the rest of the letter, and I just kind of binned it off for the rest of the day. Went to the gym, beasted myself. Came back, had a coffee, opened the rest of the letter, and it said, "However, you've been invited back to resit your ALS."
Oh, no way!
And then so for the next week, I was like in the station every day with a mannequin and drilling it like, hours, and went back the next day and injured it and got the job.
That's awesome.
That's incredible. Has the application process changed over the years? Like from when you went to it to what it is now? I assume it's. Yeah. Would you say it's harder now, or?
Yeah, for sure. Yeah.
What is the recruitment process looking like now? Out of curiosity, I know it varies service to service. If you're going for HEMS, if you're going for internal CCP, just wondered kind of what your experiences are of the process now.
The selection process has changed. And rightly so. It needs to be adjusted. The standards are, improved massively in terms of general paramedic practice. So it needs to meet that. And also a lot more people are going for it. A lot more people are putting their hat in the room and sort of saying, I want to be amongst this. Because for me, it is. And for the individuals that are attracted to that job, it is the best job in the NHS,
It's kind of what everyone talks about, isn't it? Like when you meet a student, you go, "Oh yeah, what do you want to be when you get older?" kind of thing, and they go,
"When you get older,
do you know what? I want to be a CCP. I want to be a critical care paramedic." And it's I think loads of people want to do it, don't they? Before they even know actually what the job is. Like,
I wouldn't say everyone. Like I've definitely met people and know people who are more passionate about the areas they're in. So I know urgent care paramedics who are definitely more like, "Oh no, I couldn't face critical care. Like that's not for me."
Really?
Yeah. So enough. Maybe obviously you've got the mindset of we all know where you want to head, and and that's it.
I'll never be good enough for that.
No,
barely be a technician.
But you know what I mean. And I think everyone. It depends what you're passionate about. I wouldn't say every paramedic is gunning for CCP, but I think we put like roles like critical care and HEMS, we put them on a pedestal, don't we? Because when we're in a moment of like, oh my goodness, what's going on? I'm lost with this patient. You look towards those specialisms to be like, come and rescue you from that situation.
That's
so
true.
You sort of put them up there and you're like, God, if I could be as good as them, God, I'd love to like rock up and just know what I'm doing the moment I rock up.
I suppose we call a CCP when we're in crisis, same as the public calls us when they're in crisis.
Yeah, exactly. Yeah, they are our paramedic.
Yeah. John's like, yeah, mate, you need to sort your life out and get better. No, not really.
And obviously, we also call our other heroes Heart when we're in trouble and we need extra help.
Absolutely.
I got you back. I got you back, James.
Yeah. That's an interesting journey, though, and I think it's quite similar to a lot of people who, because it was quite common to start in the patient transport and then move up to technician and then go to paramedic and stuff like that. Yeah. Where nowadays if we go
you
back
can come
to
entry point as a trainee technician,
that's it,
rather than
I'd love to go and do a degree in paramedic science, and have that opportunity, because I still feel like I want to be like, I still feel like I'm a student to the profession. I still want to learn. And like that old cliche, every day's a school day. It's so true, and you're only good as your last job.
But I think that sort of attitude is the right attitude to have, and it keeps you humble no matter what skill level you are, how much experience you've got. It's to ground yourself and remember that we are all still learning, and this is a learning profession. Like, nobody is ever going to reach the top of their game.
No. Yeah, exactly. Yeah. I hope that everyone now knows a little bit about John. I'm going to keep doing that every single time. That was a good introduction. So now if we move on to post-ROSC care, so we'll talk a little bit about that, ask some questions. So nationally, we all have to follow a post-ROSC care bundle, don't we? So if ROSC, for those who don't know, is return of spontaneous circulation. So when someone's in cardiac arrest and we're resuscitating them, their heart starts beating independently. That is then classed as ROSC, would you say, Sam?
Yeah.
That's about right. Yeah, sweet. So really, John, when you get called or you're on your way to a job and they've said, right, the crew have got ROSC, they've requested your assistance, what kind of things are you expecting that the crew would be doing or have done prior to or on your arrival to help you out?
And with that, what are you then bringing to the party that a paramedic crew doesn't have with them?
So it really does depend on the situation, and I realise that when you're first on scene to a cardiac arrest, depending on so many different variables, the way that the job can pan out is extremely complicated, and there's so many different things that can affect that outcome. So basically, what I'd love to see, and what actually happens are different things, and that's no one's fault, but basically what I'd like to see is to walk into wherever it is, to have good space to work, so 360 access, for it to be safe, first of all. 360 access, like a secure airway, whether that be an iGel, or two-person BVM technique, but maybe there's patients spontaneously breathing for themselves, which would be great. And if they are spontaneously breathing, then you have to kind of think, well, the airway, depending on the level of consciousness, potentially could still be threatened. So I'd like to see suction to the right of the patient and available. Adjuncts available if they're not in, and then basically just a very quick handover. So things that are pertinent to that patient and to the events that have led up to whatever's happened. So things like what I want to know is, was it witnessed? Was there bystander CPR? Was there any prodrome prior to their collapse? And what I mean by prodrome, was there any chest pain, shortness of breath, back pain, headache, neck pain, jaw pain, anything that's out of character for that individual patient. And then pertinent risk factors as well. So like if someone sort of said, this is, Dave, he's 52, he collapsed with chest pain, we're unable to get a 12 lead prior to collapse. He's got a history of angina. Already you kind of like, you're painting the picture. And not one thing in isolation is gonna like make you change your treatment, but when you bring it all together, like the history, their initial rhythm, their presentation, how they've responded to treatment, their past medical history, everything all together, that really does help guide your treatment and your management of the patient. So, and we don't want to know about what they have for breakfast, what their favourite colour is, all that sort of stuff, so just pertinent, like bullet point fashion. So decent handover, no more than 30 seconds.
My face always grimaces when I'm on the chest, or something, and a critical care paramedic turns up and someone goes, right guys, I'm going to do the handover, sort of shaking their shoulders and wiggling their head. And then this CCP turns up and goes, right guys, what's the story? And he goes, this is and then he starts giving this really long biography of the patient, and you're like, oh, and everyone's just like, oh god, come on mate. And then even the CCP is like, okay, I don't really care
just
about
give
all
me
that.
the facts, like I need this is it, this is what's happened.
And that's common, but that's no one's fault. And what people need, because I do it myself, if I don't write a handover down, I find myself going and trying to remember what you did. So I just print out a 30-second strip of ECG paper, bullet points, like pertinent bullet points, like, and then you can really find it and read it out.
Oh yeah, that's cool. I've seen it before. Hems do that as well, don't they? They write.
They've got a little white pad in their knees.
Yeah, and they write it down, and then when they hand over in a hospital, they just bend over and start looking. No, they don't really do that.
Could you imagine every Hems paramedic taking the knee for handover?
That's it. Yeah.
So, in regards to how would you advise a crew to deal with that? They get ROSC, that's it. Where do they go from there? So they've just achieved ROSC, they recognise it. Okay. Where now? What do they do?
So, done with the airway as best we can. A thorough A to E, so reassessment.
Yeah.
And kind of still bearing in mind that actually the precipitating cause of the cardiac arrest may still be there. So kind of that post-ROSC period of 10 to 20 minutes is still a vulnerable period for the patient, so they could potentially rearrest. And so what I try and do is delegate one person to keep a finger on the pulse.
Yeah.
You got ROSC, keep a finger on the pulse. Tell the team loudly when it changes, like when it get weaker, or you lose it particularly.
That's an important one.
Yeah. But you'd be surprised how many people go, I lost it about 60 seconds ago, and I'm like, oh no,
why didn't you tell me?
Yeah. So finger on a pulse. 12-lead ECG. Leave the 12-lead ECG on.
Is there an optimum time frame between ROSC and getting that 12-lead, or just instantly 12-lead?
So get it on. I would prioritise a BP before that.
Okay.
But bearing in mind that the whole body's been in global ischemia for a period X amount of time, from the moment they're arrested to the moment you got ROSC, that body has been ischemic, and the cells have still been accumulating, still been metabolizing their waste products. And so what happens is you get an influx of all that kind of waste products back to the myocardium, and it causes a little bit of myocardial stunning that it doesn't really like, and so you get this hypokinetic myocardium, which becomes a little bit irritable, a little bit saggy. You get low BPs, you might get some arrhythmias, you might get some changes in some of the rhythms and stuff. So that first 12-lead ECG may be inaccurate, but leave it on. And most of the monitors now are pretty intelligent in terms of sensing when there's an ST change, and they'll just print out another 12-lead ECG.
Yeah.
But if they don't, you know that in 5-10 minutes time you're just going to repeat it, and you're going to see how that morphology of the ECG changes.
Yeah.
Ping that off to PCI if you think it's cardiac, or ping it off anyway, because a lot of the cardiac arrests that you go to, there may not be anything obvious on the ECG initially, but then they may want to go to PCI and just rule out a pathological sort of lesion somewhere there, you know.
Yeah, because I've had chats with people before about ECGs post ROSC, and they go, "Oh, does it look sort of concurrent to a post ROSC ischemic heart?" And I'm like, I don't really know, to be honest. It's all got ST depression everywhere. So is that just generally what it is? Just ST depression?
It can be. You can get something with something, you know. It depends on the individual patient, how long they've been in the rest for, what their underlying baseline was like, their general fitness, their day-to-day activities, you know, all that kind of stuff. So everyone's post-ROSC ECG is probably going to look a little bit different.
Yeah.
And that's when you kind of have to zoom out a little bit and go, right, this is, you know, a 40-year-old in arrest, and now we've got ROSC, compared to an 80-year-old arrest with a history of hypertension, diabetes, cardiac disease, you know, two vastly different patients and different physiological reserves, you know, and you kind of have to then tailor your treatment to what their baseline is like, and accept some numbers that you may not accept in another person. And some of the people bounce back really quickly, and some don't. Some take a lot longer. But optimizing normal physiology post ROSC is what we're trying to do. And there's guidelines for that, you know, oxygen saturations between sort of 94 and 96, and, you know, not over oxygenating, not keeping them hypoxic, not keeping them hypocapnic, not keeping them hypercapnic, you know, keeping their end tidal CO2 between sort of 4.5 and 5, and not overfilling them, not underfilling them. You know, it's a very balancing.
And I think this is where you look at the role of a specialist, and you go, if you look at like a normal paramedic, you know, who isn't in that specialist role yet, or like is just newly qualified, they come to this sort of post-ROSC management, they probably like don't have any of those figures to the hand at the top of their head to be like, what sort of normal range levels do I need to keep this patient at? And that's where you benefit from that sort of like, whether it be a discussion over the phone with your critical care, you know, counterpart, or whether they're there in person, like that, it's key details like that are going to save your patient.
It's been noted, hasn't it, that regular crews on the run are not seeing as many cardiac arrests as they were before. So obviously yourself, John, you know, you're probably going to, you know, 1-2 a day, maybe even more on certain days. And I think it is helpful having yourself come down with that level of experience and helping the guys out that aren't seeing it as often as they once were.
Yeah, and it's like anything in life, isn't it? You get good at what you see regularly. You know, if you do conscious practice, you know, and conscious reflection, and sort of, you know, I never kind of go away from a job and think that was the perfect job. You know, I may say that in the crew room just to, like, for banter, but but I know in my, you know, in my own sort of personal sort of level of what I expect from myself. You know, I know that I've never done the perfect job, and so, you know, to reflect on each job and think, right, what did I learn from that, and how can I get better? It's a good sort of thing.
I think that's a good way, because that's the only way you're going to improve, isn't it? And especially if you work by yourself all the time, you're not going to have like another colleague there that's like that knows more probably. Yeah. So no one can give you any constructive feedback on how you did on a job. I suppose you do like ride outs with each other to give each other feedback.
For sure. Yes, that's one of the benefits of our program is every 7 weeks we get an opportunity to work out with another CCP to ride out, and it's great, you know, because we've all got different ways of doing things, and there might be something like a little phrase or some little, you know, something, a little nugget that you go, I really like that, I'm nicking it, you know, to change your practice, and that happens on all grades, you know. I've always sort of thought I can learn from everyone, you know, and some of the people we're getting in, like really smart people, you know, from different professions, from different, you know, things, coming in as ECSWs, and you find out like they were like managing director or something, and like, you know, and so you can learn from everyone.
Yeah, there's people that have sort of, especially since COVID and that, they've gone, you know, my job just became boring working from home, and they've built up a bit of money in the bank, and they can afford a bit of a pay drop to work on the road as like
and they come and start a second career, and then bring this wealth of experience from a different background with them. Yeah, absolutely.
It's mad.
You know.
So, in a post-ROSC patient, what kind of things can you do beneficial to the patient that we can't?
First of all, like, I try and make sure that the basics the essentials have all been covered, first of all. So I come in and introduce myself, get everyone's name if I can, try and remember them. And that's a challenge. Fortunately, in our service we've got name badges, so I sort of kind of like look at them and then quickly look down and go, you know, can you do this?
And
for
then
me?
you hate the people that wear a jacket that cover their name badge. Well, I'm not learning your name, am I?
So everyone gets called mate.
Yeah. Excuse me, mate. Would you mind
yeah. So ensuring like the basics essentials have been done. Starting from the top end, if the airway's threatened, if we're not ventilating adequately, we can upgrade that to a cuffed endotracheal tube. We can do that. We can intubate safely, always with a bougie and always with a wingman. When it comes down to if we can't intubate, can't ventilate, we can upgrade that to a surgical airway, formal surgical airway. And that's something that I've not done, but I've done it 1,000 times in my head.
Yeah.
On to B, we can support like spontaneously breathing patients with CPAP if required. So that's continuous positive airway pressure ventilation.
Do you carry a ventilator?
We do, yeah. And I was fortunate, unfortunate, depend on how you look at it, to use it twice yesterday for the first time.
Wow.
So, and it worked really, really well. Yeah, really impressed. It's kind of like, it looks like something from Mothercare, but like my first ventilator, you know. But
there's a review the manufacturers will want.
but actually, it's bomb-proof in terms of like, it, you know, does everything that you'd like to do in a critical care sort of transfer type scenario, and yeah, pretty intuitive, which is great for me. So that's onto B. So we can also use our little ultrasound to check that the lungs both inflated. We can't necessarily diagnose a pneumothorax, but we can check if there's a bilateral sliding sign of the pleura in the views that we look at, which is useful in trauma patients, chest trauma patients, etc. What else can we do? So on to C. But you know, the ventilator is awesome. You know, so if we have got someone ventilating, we can immediately kind of take them off that, attach them to the ventilator. We can stick them on the ventilator settings, all preset, and we can adjust the ventilator settings to their individual patient and their numbers that are thrown out to us on the monitor, which is really useful. And that just takes away another person. Frees up another pair of hands.
Yeah, because someone, that's doing it, isn't it? So that's pretty cool.
You know, if they're still in arrest, or if they're at risk of rearresting, then we've got a Lucas device, which is a mechanical chest compression device, which is really useful in terms of patients that you want to get to hospital that maybe are still in arrest, that haven't got a reversible cause that we can deal with on scene. Like metabolic disorder, you know, they're hypothermic, maybe they're taking an overdose or something that we can't reverse. Let's get them on the Lucas and extricate them and get them into a place where they can deal with that. And sometimes if you're in a confined space and you can't get good quality chest compressions with the team that you've got, you stick it on, you know.
I think the Lucas, I've always thought it just looked brutal. Like, you see it go over a patient and you're like, compared to like the chest compressions we do, I'm like, oh.
Looks like it just ruptures all of their organs.
It does, doesn't it? How do you know like how effective a Lucas is versus like manual compressions? Is it still good?
It's so in the studies it's pretty, like they've shown that it's be not much different in terms of the studies, but what it does do is it frees up another pair of hands, and it makes it consistent, you know.
Yeah, especially like you said, if you're on the back of a moving vehicle, trying to do good quality compressions manually, absolutely. And then what about like in terms of post ROSC drug management? So you know, your atropines, your micro doses of adrenaline, bits like that.
So we can give some inotropic support in the form of adrenaline, IV, and we can also start up adrenaline infusion via a syringe driver, which is really useful in terms of avoiding the peaks and troughs that you might get with bolusing adrenaline, which isn't good for the patient. And actually, the infusion is shown to give you a nice steady state of drip of adrenaline tailored to that patient, which is useful to sustain a acceptable blood pressure that you'd want for that patient. But sometimes, you know, you have to sort of think, like, if you start them on adrenaline infusion, you might find that actually over a period of time they may improve by themselves. And so sometimes I'm reluctant to start one a little bit too quickly. I'll give them a little bit of a bolus with adrenaline, see how they respond, and sometimes that's enough for them to sort themselves out physiologically and get back to some sort of hemostasis in terms of their function. You know,
I suppose that's probably the other benefit of having a CCP at any job, really, is that because you've got so much exposure and experience in dealing with that patient, you can say that. You can say, yeah, you know, I'll give them a bit of adrenaline to see how they respond. Where a lot of us, we don't have the experience of seeing all of these different patients, these caliber of people responding to that amount of adrenaline, and so we can't really make these decisions on. We can only we're told by JL Calc to give.
I was going to say we're bound by our guidelines, aren't we, as well? And I think people are very quick and sort of just to be like, well, the book says this, I've got to do what the book says, and then it puts them on edge to try these more sort of supportive inotropic things and other bits along the way. But you know, you can always end up, again, if CCP is not available, you can always end up going through like a phone call version of that where someone talks you through it over the phone, which I think, again, as we progress as a profession, we're seeing all these sort of more supportive pathways available to us. And it's so important that we utilise them and we don't carry any sort of like ego of, oh no, I don't need that, I can do this all myself, because you can't.
That's it. That's about knowing your limitations, which we will come on to in a bit.
That would have been a great link if we were there.
Yeah, if we were there, damn. God, Sam. So is there anything else you want to touch upon in terms of post-ROSC care, your role in that, or any questions?
You've got post-ROSC sedation as well.
Yeah, I'm just kind of brushing the surface at the moment.
That's it, I was going to say, like, the thing is, when we sort of when we said, right, we've got John as a guest, right, let's try and get the most out of this podcast. And I said to Sam, we could talk to John for 12 hours about the role of a CCP, the benefits and stuff like that. And so, I think we're going to have to literally just scrape the surface of all of these different things.
Well, we can always get him back another time.
Exactly, yeah. But I think it's brilliant. So sorry, post-ROSC sedation.
Yeah, so staying on C for a little bit. We can like, if they go into a tachyarrhythmia which is unstable, we can deal with that in terms of shocking them if they're unstable, but with a pulse. So if you get like a tachyarrhythmia that's causing shock, syncope, myocardial ischemia, or heart failure, we can deliver a synchronized shock, so that'll sync with the so you don't deliver the shock with the R on T and cause damage, which is really useful. And then we've got amiodarone as well, which is useful, antiarrhythmic drug. And then conversely, we can deal with the bradycardias as well. So bradycardic but with a pulse, but showing signs of shock, syncope, myocardial ischemia, that sort of thing. We can start to pace if they're unresponsive to atropine, that is. And sometimes, if they're peri-arrest, you might want to start pacing and kind of like first of all sort of thing, and just apologise to the patient, say this is going to hurt, we're going to like sort you out now with some ketamine and sedate you and take that away, that stimulus as well. So staying on C, actually we can thrombolyse intra-arrest as well.
Yes, that's right.
So if you guys go to a patient, chest pain, you capture a 12-lead ECG, it's showing elevation, or they meet the Wells criteria of a massive PE and they collapse with shortness of breath and a history suggesting PE, then that's an unequivocal indication for us to come in and hit them hard with a thrombolysis. The evidence is still a little bit sketchy, but sometimes like I might make a quick consultant call, and that's the benefit of our program as well, as we've got some awesome top cover doctors that have all pre-hospital care experience. Some of them I've worked with on HEMS, which is useful because they kind of know you, who you are, what you're about, and you can have a sensible discussion about treatment, patient trajectories, and plan a sensible clinical plan for the benefit of the patient.
Because after thrombolysing someone, don't you have to carry on resuscitating them for like an hour and a half or something?
Yeah, you're committed for 45 minutes. So, and that's the case. So, like So, for example, you get called to chest pain, ACS history, 12 ECG suggesting they have acute myocardial infarction, and then they collapse, unresponsive, VF, you shock them, and they're still in VF, then I'll come in and thrombolyse them, or one of my colleagues.
No, it's just you, John. You're the one covering the whole of England. John will come to your cardiac arrest patient. No, I'm only joking.
And then that's when the chest compression device, like the Lucas device, comes into handy, so we can get them on the Lucas and get them and get them into PCI, and they can still do their thing in PCI when they've been thrombolyzed. They just need to know. And then on to D, so disability. We want to BM. We want to assess their pupils to a degree. It's not prognostic, but you just want to still see how they go. And then if they start like a little bit agitated, a little bit light, and start making some movement, start making some respiratory effort, we want to like take away their pain first of all, and then we want to keep them sedated, keep them asleep. And we've got 2 agents to choose from. We've got ketamine, or we've got midazolam, depending on the patient and depending on their physiology at the time and their age, their frailty, etc. And if we've got a cuffed endotracheal tube in situ, we can paralyse them, use a neuromuscular blocker to stop them breathing and get them on our ventilator and optimise their hemodynamics and their respiratory function with the ventilator and inotropic support, etc. So it's kind of there's quite a lot to you get some really needy patients that you end up spinning plates, and that's when I really lean on people on scene and go, guys, I really need you to do this and this for me. My bandwidth is going to be taken up setting up this or doing this, and unfortunately the area that I work in, we've got some really awesome clinicians I can just delegate and just
Apart from there's a guy called Sam.
I knew it.
No, that's really interesting, and it kind of goes to show, like, and I see it a lot, and I think we all see it a lot, and it's happened to me before where your bandwidth goes, and then you go, do you know what? I don't actually know what I'm doing here, and then you just start getting really, you lose focus, and then
you start doing really random things like that, just are pointless to.
Yeah. And I feel like that you've got to be so integral and so with yourself in terms of your level of focus and bandwidth, and you've got to know when to say, look, I need to do this now, and then can you do this for me or whatever? And I think that's a skill in itself, isn't it, really?
Definitely. And with like all these extra skills that you bring and all this additional care that the patient gets, do you know, like, roughly, not the exact figures obviously, but like roughly how often those patients that you do all this for, you get a discharge to a survival to discharge? Like
the service that I work for has just released a out of hospital cardiac arrest report from last year, and it's showing that it's the summary is that it's showing a definite benefit to have a CCP on scene to these patients.
Job security, tick.
Yeah. It's difficult to prove. There's so many different other variables, but you'd like to think common sense would take in place. You get a good paramedic that's gone through a selection process, that's gone through a postgraduate, education, that's gone through more hospital placements, that's had rotation on HEMS, working with amazing doctors, and having those conversations and increasing knowledge and then getting sent to the high acuity jobs regularly, so you get the exposure as well. And then giving them all these other skills, you'd like to think that would have a positive outcome on the patients. But again, very difficult to prove, very difficult to evidence.
That's mad, isn't it? I think that's so interesting. Did you want to say something, James?
I was going to say that that document you were talking about out of hospital arrests, is that a publicly accessible document that anyone can read?
Yeah, it is. Yeah, it is. It's on the internet. Yeah, you can get it.
I think every trust publishes them every so often, don't they? Yeah. So then it's difficult to like lead a scene in any situation. Sometimes you can be in a football field with someone who's injured their leg or whatever, but typically in the cardiac arrest or ROSC situation, you've got family members and bystanders that can be quite difficult, but also crews can be quite difficult, like ambulance crews can be quite difficult to manage as well. How do you manage those crews that you ask to do something different to what they're doing, or you try and give them some constructive feedback on how they're bagging the patient or something, and they give you a really bad sort of reception when you sort of talk to them about that? How do you deal with that?
It is challenging sometimes, but generally what I try and do is to get compliance. I try and help them understand why. Like, I always bring it back to the patient, so it's never about me and my decision. First of all, I want to understand what they want to do. Like, if they want to, for example, if they want to bag the patient slightly different to how I'm suggesting, I go, okay, why do you want to do that? Like, help me understand why you want to do that. And if they can't give me an answer or can't give me a satisfactory answer, then I'll tell them why I want to ventilate them the way I want to do. And sometimes you haven't got the time to explain, and you just sort of say, that's a really good point, I understand where you're coming from. Now's not the time and place to have a discussion about it, but we'll bring it up in the debrief, and I'd really like to understand where you're coming from. So it's acknowledging what they want and getting some understanding, but I always bring it back to the patient. It's always about the patient.
That's quite a good way of doing it, because no one will turn around to you if they don't have any evidence or reasoning to why they're doing something. They're not going to then still carry on saying no once you've quickly reasoned why. Oh, really?
Yeah, really?
That's
what's
mad,
like?
isn't it?
What's the most difficult sort of crew situation you've ever had to deal with? Can you like recall anything that sticks out?
There's a guy called Sam on an arrest.
Right, okay, you can't stop it.
I'm going to keep doing this.
So I'm fortunate enough to work with John regularly. We work at the same ambulance station, and I've worked with and learned amazingly from John, which is why Tommy keeps referencing.
Off the top of my head, I can't really think of anything. No, and it's never malicious. You know, people don't come to work to be difficult. You know, and a lot of it is understanding. And when you kind of zoom out from it. And go, I wonder why that crew were narky. I wonder why they were a bit prickly with me. And often it's sometimes my fault, because I've come in when I reflect and gone, I've not acknowledged them, or I've done something completely unintentional to upset them, whether it's not listened to them, like I haven't heard them or whatever. And so it's important for me to not like. It's important for everyone not to take it personally, and to detach a little bit from your personal sort of feelings and go, you know, they probably didn't mean it that way. You know, and so now I've kind of changed my practice and tried to like include everyone, and I lead from the back. I've got this kind of philosophy of arriving on scene and kind of doing my like read the room sort of thing, you know, like you walk in and you go, actually it's this crew, like they're all over this patient, they're doing everything. So for me that kind of makes my job easier. I go, okay guys, you know, I'm here, but like it seems like you've got it all covered. How can I help? What do you want me to do? How can I slot in? Sometimes I'll just get a scoop and a trolley, you know.
Oh really?
Yeah. You know, like if the crew's all over it, you know, I don't need to come in and change anything and do anything, you know. I empower them, you know, it's their moment, it's their patient. You know, but conversely, if things aren't getting done and that patient is like at risk, then I will have to tactfully sort of step in and go, guys, you know, I'm just going to do this. But I'm also mindful that when you get eyes down and you're doing something to the patient, you lose situation awareness about whatever everything else is going on. And so again, you dip in, do an intervention, step back out, and then kind of lead from the back again, get a better understanding about what's going on.
Yeah, and I think because not only have you got all of these extra skills and these extra knowledge about the different drugs that you have to give, and you know all of the different things that you then sort of add on top of what you learnt when you were a paramedic, without the critical care speciality, you've got to be a leader as well. You've got to be like a people's person, and you've got to be so many different things to sort of like build this CCP. And I suppose, do CCPs have different leadership styles. So I know you said that you dip in, dip out, lead from the back kind of thing, and so you can have like that view of what's going on. Which, to be fair, I think if I was a leader, I'd probably prefer that kind of view as well. What about you, Sam?
I think we'd all be doomed if you were a leader.
I mean, it will never happen. Luckily, thank God for the people of England.
I don't know. Like leadership wise, I think I'm similar to John. Like I let people get on with it and do what they're happy doing, and then if I feel there's a need to step in, then I'll step in and offer what I can. But I'll do it in a way that supports what they're already doing. I won't take away from that because, like you said, it's their moment and they're doing everything right. And I think that's the right way to be, is not to come in so headstrong, because you then also lose the respect and support of your colleagues that are already managing your patient.
Yeah.
And you don't want that, because you're trying to work as a team to achieve, like you said, ultimately what you do is for your patient. It's not for your own egos and for each other. You're doing it because you want a better patient outcomes. And the best way to do that is to work as a team. And you're not going to have that team effort if you go in headstrong and try and delete the work of the rest of the team.
Yeah. It's a difficult one, isn't it? So, we speak a lot about ROSC, and I think at uni you learn a lot about ROSC, but we barely see it, do we? Like, maybe you might see it a bit more, John, than what we do. Well, you probably do see ROSC more. But what we don't get taught much is breaking bad news, do we? I mean, I haven't learned. They all focus on ROSC, your ROSC management, and then, but really, majority of the patients that we go to in cardiac arrest unfortunately die.
Yeah, sadly.
And we don't get taught how to deal with that. So, in terms of breaking bad news, John, do you, considering the amount of times that you might be exposed to that, do you prefer to break the bad news, or do you prefer the crew to do that? Because I think about it in my eyes, and I sometimes think if I was going to be the one to break the bad news every single time, that's going to mess with your head a bit, right? Maybe not, I don't know. It depends how you deal with it all.
I kind of reframe it in my head and sort of think, like, it's my responsibility to, as senior clinician, I see both sides of the sort of argument, if you like. And I know colleagues that do like to delegate and that suits them, and that's right. I think it's a personal thing. For me, I kind of want to be there if someone else has already made contact with relatives, friends, whatever, already, then I'd like to be there and just sort of say, and I don't say I'm a CCP, I just say I'm a senior paramedic. I tell them my name, and often I'll go to them intra-arrest, leave the team, delegate the team leader role, and go to them intra-arrest and kneel down next to them and get their name, get their relationship with the patient, get an understanding about the events leading up to, and then I'll ask them what they understand about what's going on right now, and then I'll fill in the gaps, and tell them in layman's terms what's happening. His heart, her heart stopped, whatever. They're not breathing, and we're doing everything for them right now, and everything that they're getting done here would be done in hospital. So kind of that reassurance, really.
I think that's quite a good line, isn't it? I've heard that from other people when they say, everything that we're doing here is no less than what they'd be doing in hospital, and that's kind of reassuring, because I know a lot of people go, can you just take them to hospital?
Yeah, you do get that, like, why aren't they can help them in hospital? Why aren't they in hospital?
Yeah. That's what you kind of have to get into their heads a little bit in terms of the understanding, helping them understand and comprehend what's happening and how we're making a difference to the patient.
Have you got any tips to break bad news? Because we see it, and I'm not very good at it. I've done it a few times, and I think to myself afterwards, I think, oh God, why did I say that, or why did I do that?
I hate reflecting when, it's good to reflect. That sounds so bad, but I hate, you get that cringeness of, oh God, why did I say it that way, or shouldn't I? Oh, I should have said it. And hindsight is so. Yeah.
And then, guys, I did a job. I mean, this was a while back now, but they said, oh, so. I explained it to him. I said, look, I've got some really bad news. Unfortunately, she's not going to make it. She's going to die. and then I gave him some time to sort of like figure it out, and then he said, so she's definitely gone then. And then I don't know, my head just went somewhere else about what we're going to do next with all of our kit and stuff, and how we're going to get all the family and say goodbye and stuff. And I went, yeah, she's definitely dead. Like that, and it just sounded so awful,
so passive, and like
it was just so too. I know that they say be straight to the point, but I don't know, it was just too straight to the point. And I just thought, oh God, how could I make that better? And I suppose just focus on the conversation a little bit more rather than just leave it in my head straight away. Yeah. But even starting from the beginning of initiating that conversation, have you got any tips for the people listening, and even us, to be fair, because we could always.
Yeah, I'm no expert, but I go to a lot of them, and I think the warning shot is good. The warning shot, intro arrest. Are we winning, or do we think that this is their clinical trajectory is going to like continue in a downward trend, and they're going to like die, and we're going to be unsuccessful in terms of resuscitation. So the warning shot is good, and then you leave them, you leave the relatives, the friends, and then you go back to the team and continue to resuscitate, and it gives them time then to prepare themselves. And if I think that we're not going to win, then and we're not going to get a ROSC and have a meaningful survival, I'll tell them, I think you should prepare yourself for the worst, unfortunately, but we're going to continue to resuscitate and see how they respond. And then if they don't respond, then I'll go back to them and then say, unfortunately, due to the treatment that we're giving them, and they're not responding, they're not improving, they're actually deteriorating, and then pausing and give them and kind of giving them that few seconds just to comprehend what you've just said
and process and fully
and not being uncomfortable with pauses at that point, because it is like they're going to remember the words that you say for the rest of their lives.
Yeah, that's it.
And so by keeping the pauses there, and by using terms like they've died despite our efforts, and sometimes it's useful for them to see the efforts if they want to. It's very, very personal. Some people will want to be there, some people will want to stay downstairs, wherever, in a different room.
I like that, and I've seen it with various critical care and paramedics, where they offer the relative, they set that expectation, they go back and they let them know where it went, and then they offer them that, would you like to be in the room as we let your loved one slip away, essentially. And I think that's such a nice way of doing it,
and then if we've made the decision as a team that further resuscitation futile and unethical, then I'll offer that to the family, relatives, friends, wherever, and we'll stop chest compressions but continue to ventilate, because death, it's quite a famous quote. I think it's Peter Sophia, I think I pronounce it.
You can't even say his own name.
He said, death is not a moment; it's a process, and so it is common to have changes in arrhythmias when you stop chest compressions, and you start to see maybe some agonal breaths and some changes and stuff, and to be prepared for that. So I stop resuscitation in stages now. You stop chest compressions, expect the end tidal to drop, expect maybe to see some agonal efforts sometimes, maybe not.
Is that like the patient's last ditch of adrenaline that they're...
But I don't think people fully understand the physiology behind it. I've had some uncomfortable conversations with families and colleagues about almost breaking. So Can I tell a story? Can I? So I witnessed arrest, and he collapsed in front of a friend outside. It's a public place on a street corner, and I'm running from a distance. There's a paramedic crew already on scene, and we cut a long story short, resuscitate this guy. He's unresponsive to resuscitation. He's in a PEA. A slow bradycardic PEA. I have a look on echocardiography and there's no myocardial contractility. So I make a call to a consultant and we make the decision to stop resuscitation. First mistake that I made was we took the monitoring off. We extubated him, took the monitoring off, laid a blanket over him on a street corner, respectfully, and fire was on scene as well. So fire back then they were assisting with co-responding and assisting with chest compressions and stuff. But it was great, you know.
Yeah, you have a team of about sort of 6 people lined
just
up to do chest
queued up,
compressions.
going round in the loop.
You tell them what to do and they just do it. There's no you know, they're just brilliant. So then the awkward bit started. So he started to make some respiratory effort. Started to like make some agonal gasps, and I was explaining to the fire and to the crews there that this is common. Sometimes you know you get these what's the word? It's just like a reaction. It's like reaction, like a reflex. You know,
Reflex.
Yeah, reflex. Yeah. It continued and it started to get a little bit more frequent, and I was like, and me and the other paramedic are looking at each other and I've got a feel for a pulse and we get a pulse. Like, it's got a central pulse. It's got a central pulse. And we kind of made the decision to stop and it had been like 10, 15 minutes on the street corner waiting for police, you know, because it's a public place and everything. And curtains are twitching and seeing this blanket with the chest going up and down. And so we scooped him up, got him in the back of the truck, full monitoring on, first blood pressure 130/70. Like, yeah. And so I put GCS3, you know, unreactive pupils. So I pop in an OP airway, put him on oxygen, and hand over, and I was brutally honest to the consultant. I said this is a guy who's had a witness arrest. He's had an hour of resuscitation which he didn't respond to at any point, no ROSC at any point. I made a consultant call and we made a sensible decision to withdraw resuscitation, and then when we stopped chest compressions, like when we stopped resuscitation, 15 minutes later we get this agonal pattern start. And he was great actually. He just said this is a bit awkward, but we're, you know, we'll continue care sort of thing. And it upset me, you know. I made a back to the consultant, and you know I was quite choked up by it. I thought, what have I done wrong? You know, I felt guilty. I felt ashamed actually. And I remember speaking to my CCP manager, and I told him I felt a little bit ashamed, and he was great. He had me back in the office, and like they had brews waiting for me, and you should never say that, you know, you did the best you could sort of thing.
That's it, and I think that's so rare, isn't it? Something like that, and then I suppose it's difficult to reflect on it and go, you know, it's just something that happens, because you always think, what could I have done better? And I think that we're all that kind of person where we go, oh, what could have I done better for that person? It's difficult. It's difficult to manage that emotion, isn't it?
Yeah. And so now that's changed my practice in terms of stopping resuscitation. I do it in stages, and I stop chest compression, leave them on the monitoring, and continue to ventilate. Expect everything to deteriorate, but and then and for people that feel uncomfortable with that, I explain to them afterwards in a private area why we do it like that. Because you do get this sort of Lazarus effect, you know.
Yeah, that's the story I thought you were going to tell, was the Lazarus one.
Yeah.
Out of interest, what happened to him?
I mean, he still went on to die, unfortunately. Right. And that's what the consultant said to me on the phone. He was like, you know, sometimes the unexpected can happen, and you know, the point being is that what did you do that, like, you did everything that you could. And that's the take home. You did everything that you could, for him. And so now that's changed my practice in terms of stopping resuscitation. I do it in stages, and I stop chest compression, leave him on the monitoring, and continue to ventilate. Expect everything to deteriorate, but and then and for people that feel uncomfortable with that, I explain to them afterwards in a private area why we do it like that, because you do get this sort of Lazarus effect, you know.
Yeah, that's the story I thought you were going to tell, was the Lazarus one.
Yeah,
That. Out of interest, what happened to him?
I mean, he still went on to die, unfortunately.
Right.
And that's what the consultant said to me on the phone. He was like, you know, sometimes the unexpected can happen, and you know, the point being is that what did you do